Hello, everybody. My name is Dr. Benjamin Osborne. I'm a neurologist at Georgetown University Medical Center, and tonight's lecture is going to be about how MS affects your vision. Visual impairment is actually quite common in multiple sclerosis. Approximately 50% of patients with MS will actually have an episode of something called optic neuritis. We'll talk more about this in detail later in the lecture. 77% of patients will have gradual changes in their vision due to optic nerve damage. The optic nerve is the nerve that connects your eye to the brain, and it's actually part of the central nervous system. It's really a direct extension of the brain to the eyeball itself, and it sends all the signals from your retina to the brain. So any damage that happens to the optic nerve can compromise the quality of your vision. Studies have shown abnormalities in visual function in MS patients occur even if they've had no prior history of optic neuritis. So you might have had other MS symptoms such as double vision or vertigo or inflammation of the spine. But when you look at the actual quality of the patient's vision and you look at the back of the optic nerve, you can see that there's been some damage from the MS occurring even without a prior attack of optic neuritis. Optic neuritis is an autoimmune inflammatory condition that damages the optic nerve. Not all cases of optic neuritis are due to MS, but about 50% of the time when somebody has optic neuritis, it turns out to be due to multiple sclerosis. The onset of the vision loss occurs over hours to days. Frequently, patients might notice a smudge in their vision, thinking their contact lens or their glasses are dirty, but despite cleaning the glasses, their vision doesn't clear up. And then they notice pain on eye movement. And usually it's only one eye that's involved during a flare-up. And this may be the first episode or attack of somebody's multiple sclerosis that leads to their diagnosis. So here's a photo of what the optic nerve looks like. It's that orange round circle in the middle of the retina in the back of the eye. There's one in your left eye and one in the right eye. You can see those red squiggly lines coming out of it are the blood vessels that actually give nutrients to the retina. This is an MRI of what the optic nerve looks like. On the right side of the MRI is actually the left optic nerve with the arrows highlighting inflammation in that optic nerve. Whereas on the left side of the screen is the actual right optic nerve. And that optic nerve appears normal. So when there's inflammation of the optic nerve and you have vision loss from it, we can actually visualize that quite easily on the MRI. Whereas if you recall, when we look in the back of the eye, the optic nerve frequently will look normal when somebody has optic neuritis. There might not be any signs of inflammation when the eye doctor dilates the eyes and looks in the back of the eye. This is more common in women, as is multiple sclerosis, and typically occurs in younger patients between the ages of 20 and 40, although rarely can occur in pediatrics and rarely can occur in people above the age of 40. And it is more frequent in Caucasians, although it happens in African Americans too. And the clinical features of optic neuritis, again, are that monocular or one-eye involvement with painful vision loss occurring over hours to days. The vision loss reaches its worst point usually within 1 to 2 weeks, and then without even any treatment, the vision will start to recover within 2 to 4 weeks. But it can actually take several months to recover. Most of the recovery will happen by 3 months. Some of it can actually extend up to 12 months though. There was a large trial called the Optic Neuritis Treatment Trial that actually studied what's the best way to treat optic neuritis. No treatment at all, oral steroids or IV steroids. Before I get into how we treat it, the Optic Neuritis Treatment Trial also taught us a lot about how the vision recovers in optic neuritis. On average, somebody's visual acuity will drop from the normal visual acuity of 20/20 down to 20/60, which is significantly impaired, but not quite legally blind, which is 2200 or worse. The average visual acuity in that trial ranged from 20/25, which is a mild vision loss, up to almost 2200. 11% of patients actually retain normal 20/20 visual acuity, although we'll see you can have other measures of your vision that are abnormal when you have optic neuritis, even if your visual acuity is normal. 3% actually had no light perception, meaning the eye that was affected could not even see a bright light shown in front of that eye. 90% of the time, though, patients do have some drop in their visual acuity. What are some other signs that you might have had optic neuritis in the past? You might have noticed if you had MS and your body gets overheated that your symptoms get worse. And this was actually first described by a German ophthalmologist in 1890. He noticed that in his patients who had optic neuritis previously, after they recovered, if their body temperature rose, their optic neuritis symptoms started to come back and they had blurry vision again. If they went to exercise or they went to a hot sauna, all of a sudden that blurry vision was coming back from the prior optic neuritis. This actually was not a new attack of optic neuritis, but it's something we now know or call Utof's phenomenon. And the vision recovers or gets better once their body temperature cools off. So this now is known to occur with any type of MS relapse, not just in the optic nerves. Back to optic neuritis though. When the vision loss occurs, not only does your visual acuity sometimes drop, but you can actually have loss of color vision, low contrast visual acuity, loss of depth perception, and most importantly, loss of your visual field. So when we measure visual acuity, that's when you go to the eye doctor and they ask you to read the eye chart. You can start off reading that big E across the room, which is usually around 2400 or so, and then you can try to read down all the way down to the 20/20 line. But that's only one way of measuring vision. Low contrast acuity is another way of measuring vision loss, and it's a much more sensitive measure of optic nerve damage in MS and optic neuritis. It correlates better with visual quality of life in patients who have multiple sclerosis. It actually correlates with other ways of measuring optic nerve anatomy and function. We can measure the optic nerve thickness with a technology called OCT, or optical coherence tomography. We can actually measure the function of the optic nerve with another test called VEPs, or visual evoked potentials. And then, as I showed you earlier, we can take pictures of the optic nerve with the MRI. And if we use low contrast visual acuity, it correlates with all of these measures. So if you look on this slide, you can see the typical dark black and white letters of what we call high contrast visual acuity was the typical way that your vision is measured. And on the right, you can see the gray letters, which is low contrast visual acuity. Patients who have optic nerve disease typically do much worse on low contrast visual acuity measures versus people who have other eye problems such as cataracts or dry eyes or nearsightedness or astigmatism. Color vision is another important measure of optic nerve function. Patients who have color vision loss will typically, people who have optic neuritis will typically have significant color vision loss, sometimes out of proportion to the loss of their visual acuities. You can see here some of the color vision plates that are used in the office to measure color vision acuity. And then finally, we can measure your visual fields. Visual fields map out where you can actually see. You might have normal visual acuity of 20/20 vision, but only be able to see that in a small central island of your vision. Whereas if you have a normal visual field, you can see not just centrally, but peripherally. If you look here on this slide, you'll see on the left side of the screen, the left visual field, and there's a small black area of a dot. That's called the blind spot, which is normal. And if you look on the right side, you'll see somebody who has severely constricted visual field loss, where you can see the blacked out areas of their visual field from their optic neuritis. The bottom of the cartoon shows somebody actually getting a visual field test on a machine called a visual perimetry machine. Frequently, it's in a Humphrey visual field machine. This is a computer that can test the Humphrey visual field and then print out these visual field maps. These tests can really help measure how much visual field loss has occurred in the setting of optic neuritis or other optic neuropathies. I mentioned earlier also optical coherence tomography, or OCT. This is a non-invasive test that uses near-infrared light to measure down to the micrometer level, or micron level, the thickness in the retina around your optic nerves. Initially, if you're suffering from optic neuritis, the OCT measurements are usually normal, or they might show a little bit of swelling around the optic nerve. However, a month or two after you've recovered from your optic neuritis, the OCT can actually quantify how much axonal loss has occurred in the setting of the optic neuritis. When I say axonal loss, I mean damage to the optic nerve. The optic nerve is actually made up of 1.2 million axons, or those small nerve fibers that come from the retina that make up each optic nerve. And every time you have an attack of optic neuritis, you lose some of those axons, and the OCT can actually quantify and measure how much damage has occurred. This is a non-invasive test. Frequently, patients don't even need to get dilated for this. Studies began back in 1999 looking at optic neuritis in OCT, and even back then they mentioned that patients can have a 46% reduction in the thickness of the retinal nerve fiber layer in affected eyes versus normal control eyes of patients who have not had optic neuritis. And even in patients who have MS who have not had optic neuritis in the particular eye will have reduction in the RNFL thickness. This means that eyes of patients who have MS but have not had optic neuritis can show damage to their optic nerves over time. This has been confirmed on multiple other studies in MS patients. So the retinal nerve fiber layer thickness is an important marker that we use for tracking the health of the optic nerve in patients with multiple sclerosis. It directly measures the thickness and correlates with the function of visual acuity and low contrast visual acuity, and even correlates with the measures of the MRI. 3 to 6 months after a patient with MS has had an episode of optic neuritis, most patients will lose somewhere between 10 to 40 microns of thickness in the retinal nerve fiber layer. The average normal thickness is about 100 microns in your normal adult. So let's go through some cases now. Here's a 38-year-old female who presents with blurry vision and pain in the right eye. She noticed this 3 to 4 days ago, and she noticed pain and eye movements in the right eye. Previously, about a year ago, she noticed some hand tingling that she attributed to being due to carpal tunnel that lasted for a few weeks and then resolved. She's never seen a neurologist previously, and now she's coming to see me because of this blurry vision and pain and eye movement. So immediately, I'm suspecting optic neuritis because this is a young female with painful vision loss in one eye. I check her vision, and sure enough, her visual acuity is down 20/80 in the right eye, and normal in the left eye 20/20. We do a visual field test, and as you can see here in the right eye, there's areas of her vision that are missing significantly in multiple quadrants. She has what we call a central scotoma of the right eye. That means that there's central parts of her vision missing in that right eye. When I test her color vision, she can only see one of the color plates on the testing of the color plates in the right eye, but she sees all 10 plates correctly in the left eye. When I look in the back of her eye, her optic nerve looks normal, healthy appearing optic nerve in both eyes. So I order an MRI, and sure enough, the MRI shows abnormal enhancement of the right optic nerve. The left optic nerve appears normal. And when we look at the rest of her brain, you can see, even though she's never been seen by a neurologist previously, she has multiple lesions in other areas of the brain that are not causing symptoms that look typical of multiple sclerosis. In fact, many of these lesions are enhancing, you can see on the right side, after contrast is given. This helps confirm that she has multiple sclerosis as the cause of her optic neuritis. Now I mentioned, how do we treat the optic neuritis? The optic neuritis treatment trial showed that while steroids can hasten the recovery from optic neuritis, they will not actually change your final visual outcome. So you don't actually need to get steroids to get better vision after you've had optic neuritis. But if you're interested and your doctor recommends it, you can get IV steroids. So our patient received 3 days of high-dose intravenous steroids. 2 weeks later, she returns for follow-up, and her visual acuity is returned back to 20/20. Her color vision is not back to normal, but has improved, whereas she could only see 1 out of 10 color plates previously in the right eye. Now she can correctly identify 9 out of 10 plates. She still has some mild abnormalities in the visual field test, but she subjectively feels that her right eye vision is now 99% back to normal. Now let's look at another case of somebody who has MS and has new vision loss, but it's not due to optic neuritis. This is a 35-year-old female, and she actually has a 12-year history of relapsing MS. She was referred urgently to me by her neurologist approximately 1 year ago. She noticed an abrupt change in her vision 1 week earlier. She describes it as blurry vision and also some loss of vision. She was working at home on the computer, and she noticed that she had more difficulty seeing the computer screen and had a hard time reading signs also. She also mentioned that parts of letters were missing on the computer screen. She actually had to stop driving because of these vision problems. She also noticed she was intermittently bumping into things when she was walking, particularly on the left side. She was referred back to her neurologist, who was treating her MS, and that neurologist thought she had some left-sided vision loss. Her last relapse from her MS prior to all this was approximately 10 years ago. She had been treated for many years with natalizumab, which is an IV medication, also known as Tysabri. But recently that year, she had a blood test showing that her antibody for JC was positive. And it was thought that it was too risky for her to continue staying on the Tysabri, so that medication was discontinued to minimize the risk of a rare viral infection called PML. Her last dose of the Tysabri was in July of 2019, 3 months prior to the onset of these vision changes. She then was switched to a new MS medication called fingolimod, also known as Gilenya, which is a once-a-day pill, and she took her first dose of that in September, which is about a month prior to her visual symptoms. So there are many things that I needed to consider in this case. Does this patient have optic neuritis? I didn't really think so because the patient didn't really describe monocular vision loss, and she had no pain on eye movement, which usually is associated with optic neuritis. So I wasn't really sure that this was optic neuritis, but that wasn't something I was strongly suspecting. Does the patient have PML, or progressive multifocal leukoencephalopathy, due to the Tysabri? Well, she discontinued that 3 months ago, so that seems less likely, but that can occur up to 6 months after the medication's discontinued. So that needed further investigation. Or could the patient's new MS medication, the fingolimide, be causing her blurry vision? While very rare, fingolimide and other drugs in that class can rarely cause a side effect in the back of the eye, the retina, called macular edema. And that can lead to blurry vision. So that was something also that I needed to investigate. Fingolimide and similar medications, known as ozonamide or saponamide, in less than 1% of cases can cause painless blurry vision due to retinal swelling or macular edema. And that can really only be noted if you do a dilated eye exam or use the OCT machine that I noted earlier in this talk, which can actually measure and see if there's any swelling of the macula. So I saw her in clinic. Her visual acuities were actually normal, 20/20 in both eyes. And her pupils looked normal. I did not see any abnormal pupillary function, which made the diagnosis of optic neuritis much less likely. And when I looked in the back of her eyes, the optic nerves appeared normal, as did the macula. So I did not suspect this was macular edema. In fact, I did an OCT of the macula, and there was no evidence of macular edema on the OCT scan either. These are her visual fields. If you look on the right, you can see that there's left-sided vision loss in the right eye. And then if you look in the left eye, there's also left-sided vision loss. When there's left-sided vision loss out of both eyes, we call this a homonymous hemianopsia. And this is usually not due to a problem in the eye, but due to the brain. One thing that we focus on in neurology is that the right side of the brain controls your left-sided vision. So since she has left-sided vision loss in both eyes, I thought she probably had some inflammation in the right side of the brain. So we ordered an MRI. As I mentioned, this is not optic neuritis because this is involving both eyes, and it's not an eye problem anymore. This is a brain problem. And the right side of the brain controls the left side of your vision. So here are the MRIs. And if you look here, it might be a little confusing, but right is left on the MRIs. So there is significant inflammation going on the right side of the brain, which looks like an MS relapse. It does not look like PML. This patient did get a spinal tap to confirm that this was PML, not PML, and the spinal tap came back negative. There was no evidence of the JC virus in the spinal fluid. So the patient got IV steroids, and her vision rapidly improved with IV steroids. So we can use IV steroids to treat many types of MS relapses, not just optic neuritis, but other types of inflammation of MS in the brain that can affect vision. Large parts of your brain actually control your vision, so if there's inflammation in parts of your brain that are processing the vision, that can lead to vision loss in both eyes sometimes. Next, we're going to talk about eye movement disorders and multiple sclerosis. Sometimes patients don't have inflammation of the optic nerves or parts of the brain that help process your vision, but there can be inflammation in parts of the brain that control how your eyes move. Normally, to have single vision, your eyes have to move together like synchronized swimmers. That means when your right eye looks to the right, your left eye has to look to the right, and when your eyes look to the left, both eyes have to move to the left in a coordinated fashion at the same speed and accuracy. If there's inflammation of the part of the brain called the brainstem, that can lead to double vision problems because one eye might be lagging behind the other. If you look at this slide, you can see this patient is trying to look to the left, but the right eye is lagging behind and is not moving over to the left side as well as the left eye. This is called an internuclear ophthalmoplegia, or an INO, and this is not uncommon in MS and can lead to double vision. This too might get better if the patient is treated with steroids. Here's another example of somebody with an internuclear ophthalmoplegia. If you're wondering how to pronounce that or spell it, that's how it's spelled. We typically abbreviate it as INO, the letter I, the letter N, and the letter O. This patient is trying to look to the right, and their left eye is not moving over. Not even the right eye is getting all the way to the right side. So you can see these eyes are kind of focusing in different directions, leading to the double vision. Patients can also have something called nystagmus, where they have abnormal eye movements. There are multiple connections between the brain, the ears, and the eyes that can modulate and control the speed and accuracy and coordination of your eye movements. Patients with multiple sclerosis sometimes can have tremors in their hands and discoordination of how their hands move in space. Similarly, you can have the same problem with your eye movements. And if the eyes are not moving smoothly, they can actually oscillate and develop tremors, which we call nystagmus. This slide will show somebody who has nystagmus. When they look to the right, they have a little bit of beating of the right eye. And when the eyes look back to the straight movement, they also beat a little bit. And when they look to the left, there's also some nystagmus. This patient actually has bilateral internuclear ophthalmoplegias, worse in the right eye compared to the left. You can also see when the patient looks up that there's some nystagmus in upgaze. A little bit of the eyes jumping around. They're not moving in a coordinated fashion, and that can lead to double vision and blurry vision. That is the end of my talk, and if you have any questions, please feel free to ask at this time. Thank you very much.
Hi, everyone. So I'm just, unfortunately, Dr. Osborne, he was planning to be here and do the live Q&A session, but he had something urgent come up and he had to attend to it, so I'm just stepping in on his behalf.
So an unrelated question, but we'll start addressing all of them because that's what we want. How bad is depression in people with MS?
So we know that depression, we see this a lot in our patients. It's one of the most common issues that people will complain of and will talk about. So it's not a matter of how bad it is. Of course, something like depression is going to vary between people, just like MS symptoms and just the disease course with MS tends to vary between people. Just like that, depression can vary. So it's not like one label will fit everyone. Depression is a very complicated topic because it is such a subjective issue. Sadness and grief and adjusting to something or adjusting to loss varies for everyone. So depression is going to vary from everyone. Yeah, we do have certain scales that sometimes we do use to assess whether someone is clinically depressed and whether that needs to be addressed clinically. And usually when we mean clinically, that would mean either psychotherapy or medications or both or neither, right? It depends on how bad things are in terms of some of those scales that we use and how best to address it, and that's going to vary. So I hope I answered that question. It's a very loaded question, just because it is such a subjective issue that is going to differ between one patient to another, and sometimes depending on time. At the beginning, depression might be very severe, and as time goes by, maybe just with time, sometimes with medication, sometimes with psychotherapy, depression itself will vary over time.
How do you recommend functionally dealing with symptoms such as double vision, difficulty with lighting,
Yeah.
not blind but can't do anything that requires visual acuity before medical interventions?
So obviously the first thing to address when it comes to visual acuity is refractive error. So just like I need glasses, I have terrible eyesight. I'm very nearsighted. So the first thing to address is can it just be addressed with a simple eye exam with an optometrist? And you may just need glasses. Some people have astigmatism. Right? Some people have severe myopia, which basically means severe nearsightedness, like me. So that's the first thing to address. The second thing to address is how to compensate for certain visual deficits, right? On your phone, on your computer, can you make the font bigger? If lighting is an issue, can you make the screen brighter? Um, Take frequent breaks. A lot of time patients will come in complaining of blurry vision, and essentially what they have is dry eyes. So something that's very easily treated even with over-the-counter drops. When it comes to things like double vision is trickier. Um, so typically when my patients complain of double vision, I typically will have them see an ophthalmologist or a neuro-ophthalmologist like Dr. Osborne. Usually, sometimes these patients can be fitted with very special prisms in their glasses, which may help with the double vision. Um, so again, and again, is it something more severe? Could you have retinal problems? Do you need to see a retinal specialist? So the first thing is address what the problem is with maybe your neurologist or even your primary care physician. Maybe it's something that they can figure out very easily. We can typically figure out whether someone has refractive issues, basically issues with the lens itself. We can actually do something very quick at the bedside when you're looking at the eye chart. Sometimes we can create a pinhole in a card, and if you look through it and your vision actually gets better when looking at the eye chart, it probably means that you have refractive error and you may need glasses. If it's something more complicated than that, like double vision, or something that Dr. Osborne touched on in his lecture, macular edema, which is something we sometimes worry about with some of our medications, whether it is visual acuity loss secondary to a history of optic neuritis, all of that can typically be addressed with an ophthalmologist or a neuro-ophthalmologist.
Mary Bernstein. This is kind of an emotional type of comment. It says, I saw you for a consult a number of years ago with Dr. Mora when I was in my early 50s. In the same week, I had onset of what was finally diagnosed as uveitis. Can you talk about uveitis and MS? The Tysabri infusions I took completely control of the uveitis.
Yeah. So uveitis is something we typically see. So we don't actually typically see it all that commonly in MS. We see it. Uveitis is just basically inflammation of the eye, and so we can see uveitis in isolation, just uveitis, and oftentimes we see it with other autoimmune diseases. So things like sarcoid, things like lupus, and things like MS. So autoimmune diseases tend to travel in packs. So if you have one, you are at a higher risk for developing another. So uveitis just means inflammation of the eye itself. And it can be controlled with things like steroids. Sometimes some of our disease modifying therapies can also inadvertently help to treat uveitis. Because remember, autoimmune diseases are all on a spectrum. It's all about controlling that immune system in one way or another. So as you knock out or as you try to control the MS, sometimes you inadvertently can control other autoimmune problems. So I hope I answered that, but again, uveitis is something that needs to be diagnosed by an ophthalmologist. It is something that I probably, as a neurologist, just looking at the eye or even doing a basic eye exam, may not be able to determine just because I don't have the equipment for it and the training. So that's a great question, but it needs to be diagnosed with an ophthalmologist, and typically it is very amenable to treatment.
Anonymous. I had a banana-shaped area in the center of my left eye. It was purple in color. Over the time, it faded to gray. The area remains and is a blind area through which I cannot see. If this is not optic neuritis, I am wondering if this is something going on in the right side of my brain. I have MS since 2006.
So this is a very specific question that you need to address with your healthcare provider or your neurologist. Like Dr. Osborne was talking about, sometimes optic neuritis can present with visual field loss. So if you remember, he showed you a picture of, they're called Humphrey visual fields, and he had one eye that looked normal, and I think it was the right eye where most of it was blackened out. So that person had significant visual field loss or deficit in that particular eye. Sometimes that's secondary to optic nerve problems, as Dr. Osborne was talking about, but you can also see it if there's an issue within the brain itself. Okay, so again, without knowing details of your case, my suggestion is that you speak to your neurologist about it, and maybe you would need to see an ophthalmologist about it, because visual field loss can localize to different areas, from the optic nerve all the way back to the brain. Okay.
Now, does internuclear ophthalmoplegia get worse over time if there are no episodes of relapse?
Yes. So some deficits with MS and internuclear ophthalmoplegia or INO is no different, may worsen over time. So that is true. Um, that is, unfortunately, it can worsen. Doesn't always, but it can worsen over time, just like many other deficits in MS can worsen over time.
Okay. This patient has had optic neuritis that has been seriously compromised, and she doesn't know if that was a result of either the MS or a surgery to clip a brain aneurysm. She says that her eyes have been stable for 10 years, and she's asking if she should expect that to continue or if there will be worsening down the line.
So these are very specific questions, and I think would be more appropriate to be asked of your neurologist. If your vision has been stable since the aneurysm, I'm hoping that it remains stable and that someone is following this for you over time. So just to make sure that you don't have another aneurysm or an aneurysm that might rupture. So again, these are very specific questions and important questions that really need to be addressed with the neurologist or whoever is following the aneurysm. But it's a good question.
I have been diagnosed with MS for about 2 years and I am being treated with Ocrevus. I have always had great vision and can still see fine, but my left eye often feels like there is a smudge in my vision. At what point should I see an eye doctor? And are the eye doctors who specialize in neurological disorders that I should seek?
So you should, in general, and this goes for everyone, whether you have MS or not, really should be getting an eye exam once a year. If you have MS, certainly if you've had visual field issue or vision issues associated with your MS in the past, you really definitely should be seeing an eye doctor. Now, I typically, for my patients, unless it's purely someone needing glasses, but if it's outside of that, I typically do refer my patients to a neuro-ophthalmologist. We have Dr. Osborne here, we have Dr. Shin, and there's certainly other neuro-ophthalmologists in the community. So if I ever feel like it's a vision problem that I am not fully addressing and that I think is secondary to that person's MS, then I typically will refer them to a neuro-ophthalmologist. So neuro-ophthalmologists, I don't know if this is clear to people or not, but neuro-ophthalmologists can, from my understanding, can be neurologists or ophthalmologists. They're typically neurologists who would do a neurology residency and then will do, after they graduate from residency, will do 1 or 2 years, a specific training in neuro-ophthalmology. Okay, typically neuro-ophthalmologists, unless they have ophthalmology background training, are typically not surgeons. They're usually neurologists who do a fellowship on top of their neurology residency in neuro-ophthalmology. So I hope that's clear.
Miss Cindy Moore asks, I have prisms in my glasses. Will they need to be changed in the future?
It depends on how you're doing, right? If you think that the prisms are controlling the double vision, then just leave it alone and maybe go see the eye doctor once a year or every other year if you're worried about that. But if it's working for you, then I hope they continue work for you. If that changes, you can always go see a neuro-ophthalmologist for a checkup and to see if the prisms need to be adjusted.
Okay. Random question. Do you have virtual neurology visits? COVID pandemic too risky for me at this time.
Yes. So, the pandemic has really, I think telemedicine or telehealth was coming, but COVID-19 has really accelerated telehealth use. So a lot of attendings now the majority of their visits are actually being done with telehealth. For some other attendings, it's a mixture of either in-person visits or telehealth visits. It depends on, I think one of the things that telehealth cannot do, obviously, is that it cannot replace the human touch. We cannot examine you thoroughly using telehealth, and in neurology, the exam can matter. But if you are following up with a neurologist, typically you could probably get by with telehealth, especially if you live far away, if you're very disabled, and if you're worried about coming into a hospital or a clinic because of COVID-19, I think. So we are definitely using telehealth. That's the short answer.
So this is a very interesting question. Anonymous says that given that autoimmunity issues travel in packs, are there any studies that show a higher correlation between MS and type 1 diabetes?
That is a very good question. I, I, I am sure there are studies out there. I have not come across these studies specifically, but I do think I remember at least 1 or 2 patients that I've seen that had multiple sclerosis and type 1 diabetes. Now, remember, type 1 diabetes is something that typically develops in adolescence or in childhood, young adolescence, or young adulthood. MS typically develops a little bit later in life, in early adulthood to mid adulthood. Can type 1 diabetics go on to develop MS or other autoimmune diseases? Yeah, I think the likelihood might be higher than someone who does not have type 1 diabetes, but I can't recall any studies specifically looking at the correlation between type 1 diabetes and multiple sclerosis.
Okay. And with this, we have successfully finished our Q&A session for this evening. Again, I want to thank you, each and every one of you. Thank you, Dr. Amjad, for being here with us.
And I just wanted to interrupt Dr. Serrano because he's doing a lot of thanking, but honestly, without Dr. Serrano, none of this would be possible. You know, the effort and the work that he's put into it and the quality of the videos. Because I'm telling you, if I shot this video, it would be with my cell phone, and the quality and the sound quality would not be that good. So I have to say, Dr. Serrano, I think, is at the top when it comes to putting this webinar series together.
Well,
sorry, Dr. Serrano, I interrupted you.
Yeah.
Keep going.
Well, I appreciate that. Thank you so much. I mean, it really means a lot to me. But you know, it's coming from this necessity that we have to reach out to our patients outside of the clinical environment and basically just you know put a little bit of more information in terms of the little things that usually goes through the cracks when you have an appointment. Certainly, this is very special for us. Our next session is going to be hopefully in December. Usually that will be December the 29th. Okay, and then I will keep you posted with which topic is gonna be. So again, as soon as we have the link, so we can upload these questions, and we can upload these videos. We're gonna do so. But again, thank you so much for joining us tonight. And I really wish you that you remain safe in the middle of this pandemic, that your family is safe and your family is healthy. And I wish you a very happy Thanksgiving to you all. You have a great night. I'm Dr. Serrano with Dr. Farid Amjad here. And then we'll see you in the next chapter of the webinar series of MS. We want to teach you everything about multiple sclerosis. Have a great night.